Welcome to Science with Soul. I'm Dr. Lottie Valentine and the host of this podcast. I'm a physician, evidential psychic medium, international keynote speaker, and author of Med School After Menopause, The Journey of My Soul, an inspirational story about transformation, healing, and spirituality, available online at Amazon as well as other online platforms worldwide. The inspiration for this podcast came from my own life experiences. As I have journeyed through life, it has taught me that we're part of a greater divine web of interconnectedness. I have walked the path of illness, healing, and transformation. After 2 near-death experiences, I became clairvoyant, clairaudient, and clairsentient, and was guided to attend medical school at the age of 54. We will be meeting with many different types of doctors, healers, as well as spiritual leaders, educators, and other inspiring souls in this podcast. It is my hope that you will gain information and create a path to healing your own life physically, emotionally, and spiritually, and bridge the gap between science and soul. To learn more about me or to work with me spiritually for ancestral healing, medical intuitive, evidential psychic medium, or to take my 8-week-long course, Soul's Journey, Heart's Way, a course for authentic living, which will explore opening the doors to your divine potential. Available in most time zones across the world and starting March 27th, 2021. Please visit divinespiritualessence.com. To work with me as a physician, please visit drlottie.com. Welcome to Science with Soul. Today, I'm honored to introduce Dr. Mohling. Dr. Mohling, MD, FACOG, Fellow of the American Congress of Obstetricians and Gynecologists, has been board certified in obstetrics and gynecology since 2003. She attended medical school at the University of Colorado School of Medicine and completed residence at the University of Colorado Health Sciences Center, where she was the winner of the Golden Apple Teaching Award. Dr. Mohling spent nearly 2 years in private practice in Colorado before moving to Taos, New Mexico, where she worked for 13 years. During that time, she was an associate professor through the University of New Mexico, teaching medical students, physician's assistant students, and residents through outreach programs. Following 15 years of private practice as an obstetrician gynecologist, Dr. Mohling returned to training and completed a fellowship in Minimally Invasive Gynecology at the University of Tennessee College of Medicine in Chattanooga. Dr. Mohling is a fellow of the American College of Obstetricians and Gynecologists and an immediate past president for the Foundation Board of the American Association of Gynecologic Laparoscopists. She has made numerous presentations at national meetings, including ACOG, American College of Obstetricians and Gynecologists, and AAGL, American Association of Gynecologic Laparoscopists. Her research interests involve postoperative pain and recovery, as well as endometriosis. Welcome, Dr. Mohling. It's such an honor to have you as a guest today.
Thank you. It's delightful to be here with you, especially for me on this very snowy day in Portland, Oregon. So it's a perfect day to have a good talk.
That's great. I'm a little jealous of your snowy weather.
Yeah.
So I know you work a lot with endometriosis. Can you explain what endometriosis is and where in the body it can be found?
Yeah, so endometriosis is a very tricky disease. And the simplest way to describe it is that cells that normally would line the uterus are found outside the uterus, around the ovaries, around the fallopian tubes, in the pelvic cavity, on the pelvic sidewalls, and even up through the body along the pelvic sidewall, the intestines, the diaphragm, into the lung. I've seen it even on the pericardium. Just last week, I took some off the peritoneum overlying the kidney. Next to the diaphragm. And it has been found even on the spleen, in the brain, in unusual places. While I said that it's cells that normally would line the uterus that grow outside, it isn't just the same kind of cells that would grow in a person who didn't have endometriosis. Women who have endometriosis, those cells that line the uterus are actually themselves different also, and have different markers of inflammation, even the ones within the uterus, as well as the ones that are invading outside of the uterus. So these cells don't just present with a little bit of bleeding each month, but in fact create or either create or are created by a tremendous degree of inflammation. And that inflammation causes adhesions, scarification, pain, contracture of nerves, invasion even of vital structures such as the ureter, which is the tube that goes from the kidney to the bladder. So it is a pervasive and tricky disease, and is one that requires a lot of thought in diagnosing and in treating. Is that helpful?
Yeah, no, that so because I think it's often misunderstood. People think that it's a disease that just exists in the uterus, but now you've explained that it can actually appear almost anywhere in the body.
Right. Well, and it isn't really, when it's inside the uterus, we call it adenomyosis. And the other term for that in terms of like insurance coding is endometriosis of the uterus, which is really what we call adenomyosis. But endometriosis is everything else outside the body, or not outside the uterus, not outside the body, outside the uterus.
Okay, let me make sure I got this correct. So adenomyosis is endometriosis inside the uterus.
Yeah, within the muscle, and it invades the glands within the muscle of the uterus wall.
And endometriosis grows on the outside of the uterus and can be found anywhere in the body, including the brain, the heart, the kidneys, the spleen, the liver, pretty much anywhere.
Correct. But usually it's found in the pelvis and alongside even the intestines and so forth.
So people who are listening now and are wondering if they have endometriosis, what are the typical symptoms that somebody with endometriosis would experience?
That's a great question. And I'm going to say it in medical terminology first, and then I will explain it in more clear terms. So we think of, they're kind of D words. So dyschezia, which means painful bowel movements. Dysmenorrhea, which means painful periods. Dyspareunia, which means painful intercourse. Infertility, which isn't a D word, but is understood. And then finally, really pelvic pain. So pelvic pain that's either traditionally thought of as cyclic, just with the period, but in fact can extend even outside the moment of menses. It can be throughout the month when endometriosis is really severe.
Wow. So do you have to have like a heavy flow if you have endometriosis, or can it be a normal flow?
That's a really, really good question. And I think it is important to understand. Someone with endometriosis might have a perfectly normal uterus, but they have these growths outside the uterus that are causing pain, and they won't necessarily cause an abnormal cycle. So often irregular bleeding for maybe adenomyosis or other reasons goes hand in hand with endometriosis. But that question is a really astute question. You can have endometriosis and have regular periods that aren't even heavy and still have the pain of endometriosis. Does that make sense?
And how do you know? So for people who are listening now saying, well, I have really terrible periods, how do I know if I have endometriosis? Can you see this? What if I had an ultrasound, but they told me that everything was normal, but I still have all this pain. So
Yeah.
can you see endometriosis on ultrasound or MRI?
So sometimes, and that's the tricky thing. I think it really, what I tried to do when I was teaching residents and what I do with fellows is try to teach the true art of physical exam. And when I'm doing an exam to evaluate for endometriosis, I am feeling the uterosacral ligaments behind the uterus. I'm feeling how well the uterus moves. I'm sorry for those who are listening and don't like this, but I always do a rectal exam because this is one of the most important parts of the exam if you might have endometriosis. Occasionally, someone will have a uterus that moves easily. I don't feel nodules. There aren't any masses, but yet the degree of pain that they have behind their uterus still suggests peritoneal disease. So stage 1 endometriosis, you cannot necessarily feel with your fingers or see on an ultrasound or see on an MRI. In fact, you can't. However, it's exquisitely painful. And so for most women, or most people, not to be gender specific, it is so the exam, having done thousands and thousands of exams now in my career, when I touch the uterosacral ligaments on someone who has endometriosis, their response is very different from someone who doesn't have it. And rarely am I wrong by the time I get to laparoscopy. And only a few times do I get to laparoscopy and see a normal pelvis. So the exam tells me a lot. The other thing is that when there is an endometrioma, which is a mass filled with endometriosis, usually on an ovary, that will be seen very easily on an ultrasound. And generally it could be palpated on exam. Once there is an endometrioma in an ovary, most of the time there is already going to be more scar tissue and adhesions that are creating a fixation of the internal organs so they don't move as easily. And that's palpable on exam as well when someone's carefully doing an exam. The other important thing is that when I do my exam, I'm very separately feeling, here's your bladder. Is that your pain? No. Here's your cervix and your uterus. Is that your pain? Yes or no? Here's your uterosacral ligament on the left. Here's your uterosacral ligament on your right. Here's your pelvic floor muscles. Here's your obturator internus. Here's your levator. And I'll very specifically touch each one of those structures to identify what is the source of pain. Endometriosis is one of the sources of pain, and it's very significant, and we can do something about it. But if I, as a practitioner, assume that all pain is endo, I'm going to miss at least a quarter to a third, maybe even half of other etiologies of pain. And so I think it's really, really important that the exam be tailored to identify exactly what's going on. So on every patient who I see for pelvic pain, I also do my own ultrasounds. And because I do my own ultrasounds, I can identify with ultrasound how easily structures are moving independently of other structures within, and I can press on the abdomen and see, oh, everything moves as one unit, meaning it's all stuck together. Or, oh, there we go. I can move the intestines and I see that the uterus moves independently. Beautiful. That's not going to be stage 4 and it's not all stuck together. Yeah?
Yeah. So I know that it can be hard for a regular ultrasound person to see endometriosis, because sometimes people have had an ultrasound and they're told they don't have endometriosis, but then they end up having laparoscopic surgery or excision surgery later on, and they did have endometriosis, but they couldn't see it. So is that just the fault of the person not being trained properly in identifying endometriosis, or is it that it's just not seen in some patients?
Both. I think that I've been able to see lesions on ultrasound if I feel a nodule, I then know it's there and I try to see it on ultrasound, but I think very, very few radiology techs would ever pick that up. I have a really good radiologist who reads my MRIs that I order when someone has symptoms suspicious for bowel involvement. And I am not yet, I don't feel great about my own ultrasound skills to see whether there's bowel invasion yet. I'm working on that. But MRI is very, very good at picking up when there is endometriosis invading into the bowel, which I like to know ahead of time, because then I can have my awesome team come in and help me with any kind of bowel resection.
So is that the deep infiltrating endometriosis?
So let me clarify that for you. That's wonderful. So sometimes people call that DIE, which stands for deeply infiltrating endometriosis. And deeply infiltrating endometriosis can be anywhere. It can be on the colon. It can be on the diaphragm. And when it's deeply infiltrating, it goes all the way through, and we have to cut a little area off the diaphragm into the lung. And we have to have a team there to take care of looking through the lung side. It can also be deeply infiltrating into the pelvic sidewall. So I would say that whenever endometriosis invades past the peritoneum, invades past the surface tissues, that it's become deeply infiltrating. And there can be advanced DIE, where you have big nodules and you really have to carefully surgically excise them and protect other overlying structures, such as the ureter.
Yeah, so it can be quite invasive.
It can be as invasive as a cancer.
Mm-hmm. Yeah, I've heard that comparison, that endometriosis is more like a cancer because it just sort of grows on its own and it's taking over different organs in the body, just like a cancer would, but it's not a true cancer the way we classify cancer. Would you say that that comparison is correct, that it's a growth like that?
You know, from a surgical perspective, it certainly feels that way. And when you have such an advanced stage of endometriosis, even the adjacent blood vessels are involved and invaded on, and the tissue becomes entirely distorted. The planes are distorted in the same way that cancer will do to tissue.
I know you mentioned during the exam that the exam was really important, and the rectal exam is so important. Now, why is it that the rectal exam is so important?
So it's important in cancer too, by the way. A large percentage of invasive endometriosis ends up in what's called the cul-de-sac. And the cul-de-sac is this area between the vagina and the rectum. And that area sometimes gets completely filled with endometriosis and the rectum gets stuck to the back of the vagina. I guess last week, or maybe the week before, it happens periodically, but not that commonly. I'll do a speculum exam on someone who's sent to me for pelvic pain, and you can see endometriosis invading all the way through the vagina. And that cul-de-sac is going to be completely filled with endometriosis. So, what we call obliterated. The best way to feel that is with one finger in the vagina and one finger in the rectum. And that allows for the best assessment of that cul-de-sac and also of the ovaries. So it's an exam that as gynecologists we learn in our training, mostly on the oncology wards or in the clinic, but it is crucial to do that exam when you are suspecting invasive endometriosis. That clarify that?
Yes, very good. Now, who has endometriosis? Sometimes when you look online, it'll say, teenagers can't have endometriosis, they're too young, or career women are the ones that typically get endometriosis. who would you say, is there a specific group, or can anyone get endometriosis?
Well, really, anyone can get endometriosis. It's not specific to race or social class by any means, or even it's not even, I guess, related to scholastic achievement. So it's not as though most career women are more likely to get it. I personally believe that for severe endometriosis, that people are born with it, that it develops embryologically, and that during embryologic development, those cells that should migrate and become part of the whole uterine system get stuck along the way, and get stuck along the ureter, get stuck in the cul-de-sac, get stuck on the ovaries, instead of making it all the way to the uterus. And then when the person goes through menarche and begins to have estrogen produced by their body, the cells begin to flourish, and the person begins to have pain. So teenagers can absolutely get this disease. And in fact, I believe it's really, really important that we identify this disease earlier before it becomes so invasive into the bowels, into the ureter, into the diaphragm, and so forth. If we can identify it earlier, we can probably excise it and prevent progression. We don't have enough data on that or studies on that, though.
So you say excises. What's the difference between excision surgery and ablation?
So an ablation surgery, usually both are done laparoscopically. And the surgeon will go in with a scope and instruments and make a diagnosis, see some dark spots usually, or maybe some red spots, and say that looks like endometriosis. That's probably causing the pain, and cauterize them or treat them with laser. Usually people use cautery these days, not so much laser. Some surgeons use laser. But what's happening in that circumstance is that the surrounding tissues that are also involved, or the tissues that are deeper, are not getting addressed. So if you think of an iceberg, that you can see the tip of the iceberg above the water, but there's a huge amount of that iceberg beneath. The ablation is just melting the tip that's above the water and paying no heed to that massive part that's down beneath the surface. And so it will, I think some studies have shown that patients feel a little better for the first 6 months, and there may be some neurologic disruption, there may be some placebo effect. It's hard to say why they feel better temporarily, but the pain always tends to recur. So it is my belief, and it is the belief of a lot of surgeons who specialize in endometriosis, that you really have to excise that whole bit of endometriosis, not just burn the surface, if you are going to affect someone's level of pain.
So it's like a cancer. We wouldn't just go in and burn the cancer. We actually excise it with margins.
Well, that is definitely a good analogy.
Right?
Yeah.
I mean, if I had cancer, I certainly wouldn't want them to just, we just burned it and it's still there. Like, please take it out with nice margins.
That's correct.
Yeah. So many times I've heard stories of people who have had laparoscopic investigative surgery, and they're told, we didn't see anything. We couldn't find any endometriosis. And then they continue in the severe pain and agony for another few years until they find an excision surgeon who goes in and then, finds out that, they have deep infiltrating endometriosis and it's everywhere, even, on the diaphragm. And why is that? Why do these people have an investigative surgery and then are told that, we didn't find anything? How is that Why does that happen?
Well, I think that it has to do with training, and it's partly to do with training, partly to do with surgical skill. I previously had no idea how to actually excise endo. I was terrified. I didn't know that what I could do with a laparoscopy set. I had no idea. And it took me really going back to fellowship and realizing that I had to more profoundly learn my anatomy so that I would feel safe to excise and know what I was needing to get and what I was needing to preserve in terms of anatomy, and where to go and how to be careful and how to get into the retroperitoneal spaces to actually keep the important structures safe and remove the disease. So that's one thing. Another thing is that it takes a long time to actually excise. And unfortunately, insurance companies pay the same amount to someone to put a scope in, make a diagnosis, burn a couple things, as they pay me to do 6 hours worth of excision.
That's crazy.
It is crazy. It's crazy. So it's a big problem because there's no incentive for a surgeon like myself, other than wanting to really do a good job and have someone feel better. There's no financial incentive because it takes a really long time. It takes much longer to excise than it does to diagnose and burn something and say, oh, there's nothing really else I could do. But if you're not trained to know how to separate the rectum from the vagina, you're not going to want to go near that, because you don't want to cut a hole in the rectum if you don't know how to fix it. If I cut a hole in the rectum because endometriosis is sitting there, I'm just going to fix it. That's because I've been trained to do that. But most gynecologists, 98% of gynecologists, are not trained to do that. And so,
yeah, that could be a problem. Then they see it.
Yeah.
Even if they saw it, they can't do anything.
Correct.
Because they're not trained.
Correct. Then the final answer to that question is that in some earlier stage disease, it's not obvious unless you have a trained eye. And sometimes even when I first look in with the laparoscope, I'm like, I don't see any disease here. This looks okay. And then I move the ovary, I look underneath, I look to the side, I look more carefully. Oh, I see that there are constrictions of the tissue and subtle changes, and the pathology comes back endo. So I've learned over the years and study and careful attention that endometriosis doesn't always appear like a powder burn and doesn't appear like a red bleb. It has many different faces, and probably has different faces relative to a cycle in an individual person. The other thing is that, for example, this last week I had a diaphragmatic case in someone who'd had 2 previous surgeries. No one had recognized the diaphragmatic disease. And initially, when I looked up at the diaphragm, it looked really quite healthy. I saw one little dark spot. So I said, and I had the anesthesiologist reposition the table. And then I used instruments to gently push the liver aside, and saw massive disease underneath the liver. And so fortunately, I have really excellent team. And I wasn't expecting this week. I was not anticipating. Usually I anticipate disease, but this one caught me off guard. But I got my colleague, Dr. Jeff Watkins, he's an amazing guy, came in and he did VATS. So that's thoracoscopic visualization from inside the lung cavity. And we could see that it did invade through the lung. And so then I just had to remove that whole area and sew it up. But she'd had 2 previous surgeries, one of them by someone who's quite qualified, and it had not been visualized. And this even extended down onto the kidney. So it tells you that we who are investigating pain need to, one, believe the patient, and two, be very thorough in the way that we are examining before and during surgery, to really, as thoroughly as possible, look for disease.
Wow. You often hear, now you've already explained that endometriosis grows on the outside of the uterus and adenomyosis is endometriosis inside the uterus. Now you often hear people saying that, oh, I have endometriosis and I'm going to have a hysterectomy. But if they don't have adenomyosis and they don't have endometriosis growing on the uterus, then they're really not treating endometriosis, because endometriosis could be in other areas.
Absolutely. And so I will do hysterectomies when someone wants a hysterectomy, but I always excise the endo also. And most of the time, most of the time it's going to be adenomyosis, where endometriosis is invading the muscle and the glands of the actual uterus itself. That to me is often an indication for hysterectomy. However, it's the trickiest thing. Adenomyosis is the trickiest thing because we're seeing it more for some reason. I don't know why. And it creates horrible bleeding, pain, and infertility. And so for someone who desires fertility and they have this disease within the muscle wall of their uterus, it makes it a really challenging thing to try and treat to preserve fertility. So usually we're going to attempt some type of hormonal therapy in that setting for preservation of fertility. But if someone just has endometriosis and they have pain but fairly normal periods, but their periods are painful but normal flow, doing a hysterectomy alone will not cure their pain. They will continue to have cyclic pain. And even if you remove the ovaries, they will continue to have pain. So one of the things about, I think traditionally, patients have been counseled to have their ovaries removed if they have endometriosis, along with their uterus. And then you've got someone who's young with no hormones, with bone loss, with vaginal dryness, with atrophy, with so many complications there. And I think that we now know that's really not indicated. That's not the first line for that type of pain.
No, that's such good advice, because you hear that people think often that that is the treatment, when in fact it's not. So that's really good advice. And when people come to you, to an excision surgeon, how many surgeries have they typically had? Because I hear stories of people have had 7, laparoscopic surgeries before they get to an excision surgeon. Is that what you're seeing too, or?
It's so varies, because I have also, for some reason, I see a fair number of teenagers, and I'm sometimes doing their first surgery. At the same time, I will see people who've had numerous other surgeries, and I'm still finding endo. Yeah. Even when they've had hysterectomy and oophorectomy, ovaries removed, it's a little harder to find the endometriosis. And so that's because maybe the peritoneum grows over it. And so palpating with my laparoscopic instruments and on my exam prior to surgery, so I know where to look for their pain, I'm able to still find endometriosis even in someone who's menopausal. But it's a little harder sometimes to find. Sometimes it's obvious, but not always.
So is endometriosis tied to a hormone imbalance?
I think we don't know for sure the answer to that. Clearly, there is clearly, we know that here's what we know. We know that endometriotic cells are capable of making their own estrogen. They have the enzymes to convert cholesterol, essentially, and other things down the line, pregnenolone and so forth, into their own estrogen. And so that then feeds upon itself and will continue to feed the endometriotic lesion, even in the absence of ovaries or hormone therapy. So those lesions will make their own. Strong progestins, which is a synthetic progesterone, seem to suppress somewhat endometriotic lesions in some cases. So just for like hormone 101 for people listening, the basic hormones that the genotypical female makes are estrogen and progesterone and a little bit of testosterone. These are all come from a basic precursor of cholesterol and multiple enzyme pathways, and we get estrogen and progesterone produced by our ovaries. Estrogen feeds endometriosis and the endometrial lining in a healthy normal cycle, helps support it, build it up, and progesterone stabilizes it. And then we have different varying levels throughout a regular cycle. So in the same way, endometriosis is fed more by estrogen and theoretically suppressed more by progesterone. And some synthetic progesterones are a little bit more powerful in terms of suppressing endometriosis.
Well, so what are your thoughts on treating endometriosis with a birth control pill versus having surgery?
So, well, if you don't know that you have endo and you have pelvic pain with your period, you have dysmenorrhea, it's not unreasonable to try a birth control pill. And if that works well and you feel fine and you have lighter periods and you don't have side effects, it's less likely that you have endometriosis. However, if you take a birth control pill and it doesn't help at all or makes you feel worse, it's a really good chance that you have endometriosis. And so I think for teens, that's a good rule of thumb, that if a birth control doesn't help their periods and decrease the pain, they need to be further evaluated, right?
That's great advice.
So one other important thing to remember about birth control pills is that they are 4 to 5 times more estrogen than physiologic estrogen, than what our bodies normally produce. 4 to 5 times. And they are a final estradiol and different progestins, norethindrone, drospirenone, different progestins. And so they are synthetic hormones. I'm not sure that they're doing great things for endometriosis. So I think I don't know my end theory about what's the best plan for someone, because I don't like giving someone who has endometriosis 4 to 5 times normal hormone levels. On the other hand, sometimes that's what's needed for contraception, and it does seem to help some patients with their pain.
Mm-hmm. Yeah, not one glove fits all, for sure.
Not one glove fits all. That's right. But I think that it's always important to try a progestin only pill, which is almost all norethindrone, which is a progesterone, synthetic progesterone. And it should also be understood, though, that norethindrone converts and metabolizes to ethinyl estradiol. So you're still getting some estrogen if you do the progesterone only pill. But I think that's a better choice to start out with if you've had excision surgery and you need to be on a pill. Being on a progestin only one is probably a good idea. Or a levonorgestrel IUD like Mirena, Skyla, Kylena, Liletta. All of those are progestin-based IUDs. And for some patients, that's a fantastic solution. For others, it is not the answer. It causes, for some, cramping and misery, and others love it. So not one glove fits all, as you said.
All right. All right. So the last question, sometimes you hear people talking about, well, if you have endometriosis, just get pregnant. So does that resolve endometriosis if you get pregnant?
Not at all. It's crazy. The only thing about that is that if you have endometriosis and you get pregnant, it's a great thing, because the longer you wait, the harder it will be to get pregnant, because endometriosis worsens over time and can affect fertility. So it is not going to cure endometriosis. That we know for sure. It is a huge myth. So it can also, endometriosis can also complicate pregnancy and increase risk of preterm labor and other complications of pregnancy. So it is, it's an old-fashioned misconception that pregnancy will help endometriosis. It is absolutely unproven. In fact, disproven. It is disproven. We have studies that show it's not true.
No, that's such good advice, because there's so much misunderstanding about endometriosis and adenomyosis. And I feel we really need to get this knowledge into the medical schools. So for the next generation of doctors that are training today. So people who are listening that would love to have a consultation with you, how do they find you?
Well, thank you. I would be honored if anyone wants to have a consultation with me. I am currently in Portland, Oregon, at Pearl Women's Center, where I'll be for another couple of months. And I will be transitioning to another practice, and I can't quite yet reveal that, where that will be. But I have an Instagram site, Shanti Mohling MD, and I'm also on Facebook. And on both of those formats, I'll be announcing where my new location will be. So.
That's great. And I will put those links in the podcast notes as well, so people can just go click on it and find you if you did not catch the Instagram or website name. So I just want to thank you so much, Dr. Mohling, for coming on the show today and sharing your knowledge with all the listeners.
Thank you, Dr. Lata. It's been an honor, really. And it's always, every time people ask me questions, it triggers me to think more about what are those things I need to learn more about? What other ways can I educate my patients, or can I help my patients? What are the things I still need to be learning about? Because every day I'm learning, and my patients teach me a lot. So
yeah, it's been an honor to have you on the show today. So thank you so much for your time.
You're so welcome. Thank you.
I hope you enjoyed listening to this episode of Dr. Lottie Science with Soul. Make sure you are subscribed so you will be notified of new episodes as they become available. To learn more about me or to work with me spiritually for ancestral healing, medical intuitive, evidential psychic medium, or to take my 8-week-long course, Soul's Journey, Heart's Way, a course for authentic living, which will explore opening the doors to your divine potential, available in most time zones across the world and starting March 27th, 2021. Please visit divinespiritualessence.com. To work with me as a physician, please visit drlottie.com. My book, Med School After Menopause, The Journey of My Soul, an inspirational story about transformation, healing, and spirituality, is available online at Amazon as well as other online platforms worldwide.